full of people that are not all surgeons, anesthesiologists, and obstetricians. Some of you may have gone to the opening session Monday. There was a speaker, Richard Horton. He's the editor-in-chief of Lancet. And he shared in front of all the ministers of health, live stream, that he had metastatic cancer. And he had to have a procedure. And it was just done, I think, 8 to 10 weeks ago. And he praised the NHS in the UK. And the theme of today's event is really about leaving no one behind. And so many people are being left behind. Just give you a little bit of background on how this meeting came about. I work in the program in global surgery and social change at Harvard Medical School. Gene Buckman's group is the Lancet Commission on the NCDs and injuries for the poorest 1 billion. And then PIH, they work in 12 countries, and they're moving into universal health coverage. And we said, can we do an event that highlights what it looks like on the ground as we deliver UHC? Because I think sometimes we lose focus on what UHC can be or is because it becomes abstract and conceptual. So that's what this meeting is about. So our opening speaker, I'm pleased to tell you that we have two foundations that supported this event, and the first one is the Helmsley Trust. And I want to welcome Dr. Gina. She's the program director for the Helmsley Trust Type 1 Diabetes Program, which aims to improve lives of people with Type 1 diabetes. Gina.
Hello everybody, my name is Gina Giustratidou and I am from the Helmsley Charitable Trust. Many of you probably don't know who we are. We are one of the largest US private philanthropies. We started giving grants out 10 years ago, and we have given out $2 billion grants related to health. I represent the Type 1 Diabetes Program. Type 1 diabetes, as probably many of you know, it's an autoimmune disease. It's where the pancreas does not release insulin anymore. And people with type 1 diabetes have to receive exogenous insulin. Type 1 diabetes is the only disease I know of where people with diabetes or caregivers have to make those decisions for a drug that can kill them, without the advice of a physician or a community healthcare provider. And they have to do this every day in their lives, and they have to do it multiple times in a day. Type 1 diabetes is one of the many non-communicable diseases. I want you to think about your health, the health of your families, of your neighbors, of your colleagues. It can be type 1 diabetes, it can be sickle cell anemia, it can be Crohn's disease, or it can be Parkinson's. Any of these diseases are devastated. We know that patients and families suffer from that. They don't know if they have access to care. They don't know if they have access to medicines. The goal of the universal health coverage has promised us that everybody will have access. It will remove all the ifs. And at Helmsley, we have the conviction that geography should not dictate the health outcomes of anyone. And I really hope that everybody has the same conviction. And in order to realize it, I think we need the commitment of governments, philanthropies, private philanthropies like us, healthcare workers, private sector, everyone. I really want to thank you for being here, and I want to thank Partners in Health, Jean and Maya, for the amazing work that they have done, and for the great partners they are in this effort. Thank you very much for being here.
So we're going to actually move on to a video at this point. Dipesh Rai, living in Nepal with rheumatic heart disease. The aim of this video is to highlight the lived experiences of people living in severe conditions, such as with RHD. Stories like Depesh's needs to be front and center when we're talking about UHC.
आउने टाउकोले पनि धेरै अनि यो खुट्टाहरू अलिक गले जस्तो हुने त्यस्तो हुन्थ्यो अनि डाक्टरले भल बिग्रेछ भने पहिला त एउटा बिग्रेको थियो भने पछि अब अपरेसन गर्नुपर्छ भने अपरेसन नगरी अनि यहाँ आए अनि अपरेसन नगरेर घर आयो
किन
अनि अब पैसा आर्थिक पैसा नि थिएन अपरेसन गर्नलाई
अब यो काखमा नलगी हुँदैन बिसोक हुँदैन भने बाबुलाई अहिले मात्र हैन यो पल्टोसम्म 3 पल्ट हो कि कति हो 3 पल्ट लैसे काखमा मात्र यति गाह्रो गाह्रो भएर अनि जचाउँदै ल्याउँदै पोहोरको वर्ष चाहिँ अनि अब धेरै नि गाह्रो पोहोर चाहिँ बेसरी गाह्रो भएर अब अपरेसन गर्नुपर्छ मुटुको अब भेल गर्नुपर्छ भने चाहिँ हाम्रो अब खर्चले नभ्याउने भयो अनि यता गर्दामा ठिक्क भयो अब 10-15 हजार सिद्धो अनि गर्दा गर्दै अनि काठमाडौँ लान्ला अब पैसा नि भएन पुगेन छैन
अपरेसन गर्नलाई 2-3 लाख चाहिन्छ भने अनि अब घरको आर्थिक अवस्था नि कमजोर थियो अब त्यो औषधि खाएरै ठिक हुन्छ भन्ने त्यो बिचमा अब ठिकै अब अलिक बिसोक भए जस्तो भयो त्यसपछि अनि काम पनि हल्का गरे त्यो ट्र्याक्टर जोत्नेहरू त्यस्तै काम गरे अनि अब पढ्नु नि पढ्ने काम नि गर्यो अनि यस्तो अलिक बिमारी दुख्न थाले जस्तो स्याकस्याक हुने त्यस्तो भयो अनि त्यसपछि फेरि अनि एसएलसी दिन बेला 2 दिन अगाडि अलिक धेरै नै गाह्रो भयो अनि त्यसपछि फेरि अनि हस्पिटल गए अनि डाक्टरहरूले अनि भल्भहरू अब एउटा भल्भ बिग्रेको थियो पहिला जाँदा अनि पछि अब दुईटै भल्भ बिग्रेर एउटा अलिक बिग्रिन आँट्यो रहेछ आर्थिक पैसा नि थिएन अपरेसन गर्ने त्यही कारणले घर फर्क्यो पछि हुँदा अलिक गाह्रो हुन थाल्यो
दुईटा मुटु भेल फेर्नु पर्ने भन्नुभइरहेको डाक्टर साहबहरूले साह्रै समस्या पर्यो समस्या नमजा लागिरहेछ त्यो भिन्चाले घर पनि घट्कियो बनाउन सके छैन के कमाइ आफ्नो पढाइ छैन कमाइ छैन अब आफ्नो जागिर पनि छैन यस्तो नि अब दुःख गऱ्यो खायो त्यो पैसा अलिअलि कमाउन सकिँदैन अलिअलि कमायो आफै खानलाई ठिक्क अब अपरेसन गर्न सकेन भने अब मान्छे अलिकति गाह्रै हुन्छ मान्छेमा बढ्दैन त्यो त दुईटा भेल अब फेर्नु पऱ्यो भनेपछि अलिक अर्को एउटा भेल अब दुईटा त भयो जब 4 भन्दा हुँदैन अब त्यो गाह्रो पर्छ समस्या गाह्रो
यही बच्चाहरूलाई राम्रो होला राम्रोसित पढाउँला यो बच्चाहरूले गर्ला भने ऊ पनि अब यस्तो मुटु रोगी भइहाल्यो अब कहिले कुन हालतमा अब यही हो घरको जाला नि देख्नु भइहाल्यो हजुरहरूले यस्तो अब यही छोरोले कमाउला अब गर्ला भने यही छोरो पनि अब हुर्किया छोरो नि यस्तो मुटु रोग लाएर यस्तो भइहाल्यो अब कहिले राम्रो हुने र अब गर्ने हो यही बस्या जग्गा नि सबै ढिलो राखेको छ हजुर हाम्रो आफ्नो उसमा छैन अब कहिले आफ्नो उसमा लिएर आउने हो थाहा छैन
अपरेसन गर्नुपर्छ जस्तो लाग्छ अहिले त्यस्तै हुन्छ धेरै नै अब पछि हुँदा हुँदा गाह्रो हुँदै जान्छ अब फेरि भल्भहरू बिग्रेर के आमाको नि याद आइरहन्छ फेरि मरेल जे अनि त्यही मान्ने खालको छ अलिक म राम्रोसित पढेर अब बुवाआमालाई नि हेर्नु त्यसो बुवाआमा नि लातो छ राम्रो पढ्छु अनि त्यसपछि त्यही अब पढेर राम्रै त्यहाँ गएर राम्रो पैसा कमाउँछु अनि भएको ऋणहरू तिर्छु त्यस्तै सोच्छु
We have a happy ending. Dipesh had his surgery and is doing very well. If that short video segment didn't touch you, I don't know what will. I'm a father of 3 daughters, and there's nothing a parent wouldn't do for their child. And to have a child with a condition that you want to help, but you can't afford it, that's stinging. Beyond that, as a child, to be a burden on a parent like that is also a tremendous thing that no one should have to go through. Okay, so we move on. We are honored to have our Honorable Minister of State in charge of Public Health and Primary Health Care, Honorable Dr. Patrick Dimubanzi. I'm sorry. The Honorable Minister of State is a public health specialist with experience in designing and implementing strategies to tackle HIV and AIDS pandemic and also non-infectious diseases in Rwanda. Help me to welcome the Honorable Minister of State.
Thank you. Good afternoon. And you had it right, it's the Mobanzi, that's true. The representative of WHO Afro, distinguished supporters of the Helmsley Charitable Trust and the Keljan Foundation, our colleagues from Partners in Health and the Harvard Medical School program in Global NCD and Social Change and the program of Global Surgery and Social Change, ladies and gentlemen. It's for me a pleasure to be here, especially about this topic where everyone is so passionate, at least those we work with are so passionate about equity, social justice, access to care for all. Especially from where we come from, that has a lot of significance to us. I would like first to thank the organizer of this venue, the organizers who are facilitating this important discussion that we are having across. We had it, I think, last year in Boston. We have it, and we continue to have it until we finish this work of having everybody access to care. And until we get to the universal health coverage. Universal health coverage, as you all know, requires inclusiveness, inclusion, accountability, and innovation. If we don't innovate, we'll never get there. It requires commitment, and it requires commitment from the top level. We call it political will, but it's a commitment from everybody at each level they are on. The commitment to recognize in another human being the same rights that we have, to get access to care and to live and thrive and develop for the only 70, 80, 90 years of happiness that we should all be enjoying. So that's so true. And today, as we are here to discuss about equitable inclusion, accountability, and investments, we need to reaffirm our commitment to persevere in that goal until it's done. The USC 2030 Partnership and Civil Society have voiced in their call to action that no one, in particular the rural poor and the most marginalized, shouldn't be left behind as we shape a health system that works for all and cover everybody's needs. So I'm very grateful to join you. I will always be grateful to join this discussion. And I would like to share some of the lessons learned from Rwanda. It's critical. So in Rwanda, as you all know, 25 years ago, we underwent a genocide against the Tutsis that destroyed the social fabric, that killed so many people, that destroyed the complete health infrastructure. So we had to rebuild everything from scratch. But the way we redesigned it and the way we built it was so that health could be accessed by everyone, because we learned our lessons the hard way. Exclusion never works. It never works, and it never works for something as critical as healthcare. Moving forward, the thinking was that if we are to give care to everybody, how do we do it in a society where we don't have any doctors, at least not enough, any nurses, any midwives? So one of the decisions that we made was to task shift and task share. And we seen it a lot in the HIV program, where most of the care is provided by nurses who are trained. And it started the hard way. It was only very few specialists in Kigali. Then it went down to some few general practitioners, but there was still too few, and now the treatment is accessible in all the 505 health centers that we have across the country. We have more than 186 now people on treatment, which makes almost 85% of those in need in care. We had a recent survey last month, actually, the Rwanda Population HIV Incidence Impact Assessment, that's showing very promising results. So we are almost getting to the 90, and hopefully, they're still running the analysis, hopefully we'll be at 95, which to me is a true success story and shows that things are possible. In the 20s, for those who were in clinical practice, we used to see people dying, literally dying. 25% of our patients in hospitals had HIV. So you could walk in the street and say, this one has HIV, this other one has HIV. No, because of the slim disease. You could recognize them without even any test. People had TB, cryptococcus meningitis. Students in med school now don't even know what it is about. So it's only 20 years, because we are not that old. It's only 20 years, but the change has happened, and the change has happened for everybody. And it's the political commitment, it's the people, it's the nurses, but it's also the partners. All the partners who came together, the Global Fund, the PEPFAR, Partners in Health, and all these people who spread the treatment across the country, across the countries as well. So now, as we talking about the success story that happened in the HIV, to me, it's a model that could be replicated for all the other diseases. Because the beauty of the HIV is that it looked at the patient, the clinical aspect, it looked at the social aspect, it looked at the family, it looked at the adherence and made sure that person were taking his pills. So you looked at the person holistically so that you ensure that the treatment outcome will be as positive as possible. For the NCDs, we could replicate exactly the same. First thing that we're trying to do now is to train people. So the treatment was more especially at tertiary care level. Then we brought it down to the district hospitals, where you have at least one NCD clinic that's happening on a weekly basis. The next push in Rwanda is to bring it down to the health centers and the community. The community. Let's not make any mistake. For NCDs, as much as we focus for treatment, we need to prevent, because treatment is possible, treatment is easy. I don't know if any of you have been in Rwanda, but every 2 weekends we have what we call the car-free day. So there's no car circulating, everybody goes out, and the minister has to lead with example. So you put on your sneakers and you run, you walk, you bike. No cars are moving in some streets, and it's every 2 days. But it's also a way to send a message. Look, take care of your own health. Prevent the diseases that you can prevent. Tell it to people who are in their 70s, but also tell it to people who are in their teen ages, so that we start preventing now. In Rwanda, 40% of the population is less than 15. So if we can push to them that consciousness about their health and their responsibility about their health, it will prevent disease that will happen in the future. As I started saying, 25 years ago, we had the genocide against the Tutsis. A couple of months ago, last year, somewhere in September, we concluded a study on mental health in Rwanda and realized that the toll of mental health, the burden of mental health is very high. 12% of the general population has severe depression or signs of severe depression. 35% among the survivors of the genocide have signs of severe depression. And I'm not talking about the other comorbidities still in the area of mental health that they have, so PTSD and so on. So what we understand now is that that's the next shift, because you cannot be building a society where you have that huge burden of mental health issue potentially that will at some time blow. So what we are starting now and we're putting in place is a community mental health program, so that the community health worker, the people in the community, start taking care of their neighbors, start recognizing the signs early and refer them. Now at the level of health centers, we also have nurses, the task shifting that we were talking about, mental health nurses and psychologists who will be able to provide the care and organize a referral system, because we need to work in the context that we are in, where we don't have enough mental health specialists. And finally, I'm going to touch a little bit on the surgical and emergency care. It's a new program. Last year as well, we launched the National Surgery Obstetrical Anesthesia Plan. That's probably on the website, I think, of the school. And we are very happy, because that's also something that was missing. We did very well in public health. We did very well in preventing diseases. But now, for everything that concerns tertiary care, that we are trying to bring at the level of health district hospital, we're not doing that great. But that has a reason, because to train a surgeon takes, 15, 20 years? We are going to task shift some of the work that they were doing, but at the same time, we cannot be talking about coverage without talking about quality, because that's also an important component of the universal health coverage. So that's the next big thing that we're going to do in the health sector. And for that as well, we hope that we could gather the partnership that are needed, people who want to come and teach, to train, and help the young surgeon develop. That will be very useful. I'm talking about mostly Rwanda, but I'm also talking about the rest of the countries in Asia, in Africa, where we need to very quickly scale these programs that work, so that we save the most lives that we can save. The last point that I want to make, we will never get to HC if we only focus on the health sector, because health sector is a tiny piece. And this is something that I'm starting to understand. We are so much dependent on all the other sectors. Health goes way beyond health. It's water, it's sanitation, it's education, it's everything. And we, people in the health who understand it better, we need to reach out to these other sectors and tell them, look, we need your help here. I'm giving a quick example on the One Health element. When you have an outbreak in cows, the immediate solution is to slaughter them all and get rid. But when you have an outbreak in human beings, you cannot decide to slaughter. You have to contain, so we are the most interested in preventing, in responding, and we should be taking responsibility, saying that our mandates as people in health sector, we need to protect them all, and to protect them all is to engage all the other sectors. These are the few remarks that I have, but I want to reiterate that I'm very happy to be here. Keep on the good job. We're all together. Thank you.
Thank you, Honorable Minister of State. I'm always amazed a country like Rwanda with strong governance and commitment can achieve remarkable outcomes. Thank you. So we move on to our next speaker, which is Dr. Gene Bookman. He's a cardiologist and medical anthropologist who heads the program in Global Non-Communicable Disease and Social Change at Harvard Medical School. He's an assistant professor of medicine, assistant professor of global health and social medicine. He's also the senior health and policy advisor on NCDs at Partners in Health, where he directs the NCD Synergies project. And most relevant, he's the co-chair of the Lancet Commission on Reframing NCDs and Injuries for the Poorest 1 billion. And I'm sure he's super relieved that 3 years of hard work went into this commission, and they have just finished the product.
It's been submitted.
Submitted, yeah.
So
Congratulations.
maybe somebody will be reviewing it. So, thanks. Let me grab the clicker here. Wow. So this is really a wonderful event, and it's great to have a venue, I think, to give a little bit of our community's perspective on what's at stake with UHC. And I'd like to start with this slide, which is from a Russian prison from the late 90s, and maybe some of you will recognize or suspect what disease this patient had. But this was actually where I started in my work outside of the United States. I was born in Odessa, Ukraine, and immigrated in 1978 along with my family. And when I met Paul Farmer and Jim Kim, they were in the middle of dealing with a crisis with a disease called drug-resistant tuberculosis that they'd first encountered personally with a colleague of theirs in Peru, and then were called to work in former Soviet Union, the prisons of the former Soviet Union, where this was becoming an epidemic. And this was not, so very long ago. And at this time, our idea as a global health community about this disease was that it was not a priority, that this was a disease that was complicated to treat, that was expensive to treat, and that unfortunately there was nothing that we could do for these patients. And we knew at some level that wasn't true. That with the right resources we could actually do a lot for these patients. But these patients hit up against a general problem that we have as a global community, which is that we want to have big impact. We want to be dealing with diseases that affect hundreds of millions of people, or we want to be dealing with risk factors that are similar, and we want to deal with just a few of them. So when we're faced with a problem like this, it's hard to know what to do. It's hard to know what to do. And I think that we see this tendency perpetuating itself even as we enter this phase of discussion about universal health coverage. And I think that we should reflect back on this experience and what it taught us about what's possible, and how this moment, I think, really marked a change in our acceptance of double standards, for one standard for the poor and one standard for the well-off. In January of this year, we had an event that side event that we hosted along with the Helmsley Charitable Trust on what we called Integration Science for Universal Health Coverage and the NCDs and Injuries of the Poorest Billion. And I'd argue that one of the greatest things that's at stake with universal health coverage is our ability to deal with less common, very severe conditions that aren't amenable to our big bucket approaches in public health. And this is really the promise of UHC. But how are we going to get there? And it's going to take creativity. It's going to take learning from examples of countries like Rwanda. It's going to take shifting our thinking from disease-specific interventions to operational strategies like surgery, like emergency care, like the example of chronic care for severe NCDs at district hospitals in Rwanda. And I think all of this is some kind of an integration science that we're entering. Now, if you look at the way that we're talking about universal health coverage in our monitoring index from WHO, you can see that we have not cracked this problem. What are we monitoring? How do we measure countries on if they're achieving UHC? Well, we've imported the MDG agenda, the Millennium Development Goal agenda, where we have a few priority diseases, maybe tuberculosis, HIV, maybe we're talking about malaria, bed nets. We have some thoughts about sanitation. We're dealing with pneumonia. We're dealing with vaccinations. And these are what? These are big diseases that if you focus on them, you will have massive impact. And this worked for us in the MDG era. We were able to make a lot of progress on that. For communicable disease, this kind of works. Now, what have we done for NCDs? NCDs equals blood pressure plus fasting blood glucose plus tobacco. Is that true? I think it is not true. It is just not true. And it leaves on the table, it shoves under the rug some of the most vital issues in global health equity that we're facing. So until we crack this, and we don't even talk about injuries here, right? We have not addressed universal health coverage. And in fact, when we look at financing issues, financing gaps that the poorest countries are facing, 70% of that gap is in NCDs and injuries, and it will not be achieved without global solidarity. So when we meet this week to think about the program of work, WHO, its budget, 1 billion people benefiting from universal health coverage, what do we mean by that? Are we really addressing the most vital issues first? And are we addressing the poorest billion first, which have traditionally been our focus in global health? And I hope that this meeting that we're having today, other meetings that we'll have over the course of the year, over the course of the week, will get us closer to achieving UHC with equity and truly leaving nobody behind. So with that, I'll hand back over to Key and get on with the rest of the program, which should be incredible in terms of hearing from practitioners, policymakers, and patients, most importantly. So thank you.
Okay, moving on to the panel discussion. Please have the panelists come up. Is that Alicia? Will you be doing that? Or yeah, okay. So we go on to panel. We will have time for question and answer because all of you are here. We want to hear from you. Alicia, I get to introduce her. She's a senior clinical advisor on strategy for partners in health. And an associate scientist in the Division of Global Health Equity at Brigham and Women's Hospital in Boston. And just briefly, PIH Partners in Health, as you know, is an NGO working across 10 countries with ministries of health to build healthcare systems. Please come up.
Everybody can come on over. Good afternoon. How's everybody doing? I'm going to have you quickly stand up, just shake around a little bit, wake yourselves up while our panel is getting themselves seated. All right. Say hi to your neighbor, and then you can have a seat again. All right, go ahead and take a seat. So, good afternoon. Thank you all for coming. I'm really excited about this panel we have. They're a very interesting and diverse group of people, so I think you're in for a treat. Just briefly, before we get started with the panel, as we work with national governments to develop integrated health systems and pathways to UHC, we really need to keep the perspectives from all levels of the healthcare system in mind. And this starts with the patients themselves and people-centered care, and then moves through the community to the facilities, onto the national level, and finally the global level. And that's really what our diverse set of panelists today represent. So we've got 6 individuals organized into 3 groups. The first group, they're going to provide the patient perspective. The second is going to provide the perspective from the community and the facility. And our third group today is going to talk about both the national and global perspectives. Also, I want to take a second to keep in mind those people who are not able to engage in the World Health Assembly this week due to inequities and barriers that are faced by many. So, for example, we were supposed to have a panelist today who was a nurse from Rwanda, and he was unable to make it due to visa issues. And I think as we're talking about UHC in these high-level meetings, we really need to have the people from the poorest, most remote areas engaged in that process. Because, let's be honest, they're the ones who understand the realities best about the challenges that people are facing. And so without those people engaged in the process, we can talk and talk and talk and pass resolutions, but we're not going to make real progress towards achieving UHC. So, with that, I'm going to introduce our panelists today. Our first speaker from the patient perspective angle is Mr. Joab Wako. He is the Executive Director of Transplant Education Kenya. He was diagnosed with end-stage renal disease at the age of 24 and was very fortunate to get an organ transplant from his sister. Since then, he's been a dedicated patient advocate for NCDs, and based on his experience, he founded Transplant Education Kenya in order to promote awareness and try and raise possibilities for organ donation for others in his home country of Kenya. Our next panelist is going to be Dr. Maria Machai. She is the Senior Technical Officer on DRTB and TB-HIV at FHI 360. She is going to be able to provide both the patient perspective and the provider perspective. And that's because she developed MDR-TB while working on her postgraduate work in clinical pharmacology. And lastly, she's currently managing the Challenge TB program for FHI 360 in Mozambique. So she's going to have a very interesting perspective working at the national, district, and community level, as well as working directly with patients. So for our first 2 panelists, our first question today is, can you tell us a bit about yourselves, your story, and what have been the biggest challenges to you managing your disease, whether it's MDR-TB for Maria, or whether it's end-stage renal disease in your home countries of Mozambique and Kenya?
Good afternoon, everyone. It's a pleasure to be here. And as introduced, my name is Joab Wako, and I am from Kenya. And when I was diagnosed, I was actually in the States. I was working as an industrial engineer. And I was given the news that my kidneys had failed. So I was straight in stage 5 and was put on dialysis immediately. And I know most of you are doctors in the room, it's quite a traumatic experience to go through because there are no words to explain just that day when I was told that I have end-stage renal disease. And that is one of the most motivating points of my life now when I look back, because I was told to start looking for a kidney at that moment because I was 24. They said I'm still very young and I need to have the best treatment, which is an organ transplant, a kidney transplant. So I tell my family, because such chronic illnesses like kidney disease, such severe illnesses, it's the whole family. It's not just the patient. So my family had discussions, and we decided to start doing the transplant process, or having a kidney transplant in the States. This is in 2015. My mom flies in about a month later, and she was shocked, of course, just devastated, but we were able to start the process at Vanderbilt University Hospital, just to see what the options of a transplant are. I was lucky because my sister, right there and then, came up to me, like she called me on Skype and told me that if it's possible, she would like to see if she's a donor, and not very many people get that. So I had hope in the beginning stages of kidney disease or kidney failure, and she managed to come over, and me, my mom, and my sister went to see the transplant coordinator, who told us about our options. And that's one of the most scariest meetings I've ever had. But she walked us through the whole thing, and I remember one thing we kept asking is, how much is this going to cost? And at the time, it was a very difficult answer for her to give us, and we pushed her, and she eventually said, usually about $50,000, up to $200,000. It depends on each patient and whether you have complications. So when we had that, of course, we start planning financially and fundraising and doing the necessary, because most of these conditions affect the whole family, as I said, and they put us at financial risk just because the treatments are so expensive. I wasn't a citizen. I'm not a citizen in the States, so the insurance I had would only cover about 50%, and 50% of 50,000 is a lot of money, and it could go up to 200. So we just felt like that is so much money, and it was our family decision for me to move back home to Kenya. So I quit my job and I moved back to Kenya. And when I moved back to Kenya, I realized that a transplant is a process. It's not just something that, hey, we have a donor and you go for surgery. There's so many tests involved. And I also do my research. And at the time in 2016, because I moved home in 2016, I found out that our transplant program in Kenya, the whole country is doing about 35 transplants a year. And so just being an engineer and being very logical, I take all that information and I'm thinking 35 transplants, that's maybe 1 or 2 a month. No, yeah, about maybe 3. And this is my sister who's 28. I'm 24, turning 25. And she's perfectly healthy. There's no reason for her to go through any of this. I'm the one putting her through this, so I wanted to do my research properly. And that's when I decided that I would research other countries as well. And India is a very known option in Kenya. A lot of Kenyans go to India for complex surgical procedures. And so I started researching India, and I found out that for the money we were going to spend, it was very close. And in India, like, for example, the hospital that I had my transplant in, they were doing about 4 to 5 transplants a week, which is a lot more. So the team is more experienced. And we were also able to do laparoscopic kidney transplant, which helps with the scarring, and for my donor especially, because she was very young. So that was one of the motivations for us to do it in India, as compared to Kenya. But Kenya has been improving a lot, and I'm thankful for that. Even we have a program now for dialysis where the national insurance pays for dialysis. But for the transplant part, we still have a long way to go. And so that's why I went to India. And in end of 2016, I got my kidney transplant. So now when I got my kidney transplant, my world changed. It's like day and night. I'm able to do so much more. I can travel, I can live my life. And I felt like that everyone who is on dialysis, especially young people, they should have this chance. Like, why should I have a chance that I have friends who are on dialysis, stuck on dialysis. And to see them is hard for me because I know that there's a better treatment. I know a transplant is not a cure, it's a treatment. But that treatment should be open to everyone, and that's where UHC really appealed to me, because now if everyone is able to access a transplant, especially young people, then they'll be able to be more productive and live life, even though they've gone through such a severe non-communicable disease like chronic kidney disease. And so when I came back home, that's when I started Transplant Education Kenya, because a lot of people didn't understand outside of the chronic kidney disease kind of environment that a transplant is so vital. A lot of people would just think it's, oh, you just need a kidney, get one, and you're done. But there's just so many hurdles and barriers, especially financially, that a lot of people back at home in Kenya cannot go over. So that's one of the biggest reasons I decided to just start advocating for it. And it has been a journey that I am grateful that I started. So that's my story in short. I hope I answered the question.
Wonderful. Thank you so much. Dr. Maria.
Good afternoon. My name is Maria José. I am a medical doctor, and I was doing my post-graduation in clinical pharmacology in Cape Town when I got sick. I was there with my 2 kids, one of 3, another one with 6, and I had the support of a nanny. I was doing my work, I was studying with hope that I would finish my post-graduation, and suddenly I got sick. It was like a flu, symptoms, but there was one thing that was worried me, and it was this tiredness and a pain that I had in my back. I was doing my casualty, and I've decided to check what was going on, and I did my X-ray. I took sputum, and I sent for the exams and for culture. When I got the X-ray, I found the spot there. And I said, no, it cannot be true. And I took to my head of division, and he said, it is tuberculosis. You have to start to do the treatment. I said, okay, I'll do. I'm exposed, I'm at risk, so I'll do my treatment. So I started to do sensitive treatment, and all my colleagues, I had the support of all my colleagues, the division, the supervisors, the head of the division, the clinical pharmacology division. And I remember they said, we have to make a plan for Maria José. So I had all the support. 2 months later, when I went to do my control, I started to find something different in my evolution of the disease, because I was supposed to get better, and when I stopped this treatment for the intensive phase, the symptoms, I was feeling that the symptoms were coming back. So I had the best support of the best medical doctors and pneumologists, and I asked the doctor to check my culture. And when he went to check the culture, the results came, and it was resistance, drug resistance. So at that point, my world literally fall apart, and I said, it will be. It's a drug-resistant TB. At that time, I was not aware what was that mean. For me, it was like that. I would have to take treatment for long, which includes 6 to 8 months of injections every day, many treatments. And if I could not manage, I had these 2 kids. So I said, okay, I'll have to do the treatment, and I started to do my treatment. I had all these side effects, but I had the support of my colleagues. I was in a foreigner country. I did no family there, me, my kids, and the nanny, but I had this support of my colleagues. Back home, I didn't want them to tell. I didn't want to tell them what was the gravity of the problem, but when I started to receive the treatment, then I started to get really sick of these side effects. So I had to get the support. I had to talk to my older sister, and I had the support of my younger sister that came to stay with me to support. It was difficult. I remember my daughter, she was 6, and she always said that she wanted to become a doctor also. But then when I was sick and I had all these side effects and she was seeing me suffering, she asked me what I had. And I tried to explain to her that she could not stay close to me. She had to be aside. And it was a severe disease that I didn't want them to get the same. She said, Mom, you know, I don't want to become a doctor anymore because I don't want to get this TB. So it was difficult. I was tiny at the time. I had to take injections for every day for 8 months. I had to take, I can remember, it was around 18 tablets a day, including the vitamin B that I had to take for peripheral neuropathy. And I was reading a lot about the side effects, about the disease. I knew that I had to be compliant with the treatment, otherwise I would even get the more resistant form of TB. So I took my treatment seriously, I was compliant, and I went for the controls. In the first two months, my culture was negative. I was feeling much better. I was doing my work at home, and I also remember I was doing research in a TB hospital on adverse drug reactions, and I was excited to be part of the authors of this article, but I couldn't because at that time I was feeling so sick, and my colleagues said, please write something, try to correct something, but I couldn't. So I could not be part of the authors. I was just mentioned on that article. Then I become better, and 4 months later I start to do my work because my supervisor said that I should stay for 2 more weeks to recover, and then I would continue. And I continued to do my study. Luckily, the academic side was finished, and I started to do the field work, and I was doing my field work in Mozambique. So the academic side was in South Africa, in Cape Town, and I had to go to Mozambique to do the field work. I used to go to the nearest health facility because my work was at the rural area. I was working on malaria. And early in the morning, I would go to the health facility, take my injection, go to the accommodation, take my tablets, have some rest, eat, and go to the field. Luckily, I finished my treatment in 2 years, and on the year that I finished my treatment, I also finished my graduation in clinical pharmacology. So I said I was lucky because I was in the right place. There were tablets, there were medicines. I had side effects. They had to change. The insurance also, the health insurance was also an issue because if you are a foreigner, you don't have access to medicine. I had these side effects, and they had to replace a drug, and this drug was only available for South Africans, but the ones who decided who is going to get this treatment was my division. So I was lucky, and I got the treatment. When I was doing the field work, my colleagues and the doctors would make sure that I would receive the medicines that we didn't have in Mozambique while I was doing the field work. So when I finished my work, my studies, my clinical pharmacology. I went back to Mozambique. I said, okay, my thesis was in malaria, but I want to be involved in TB. I want to go for TB. I want to go for MDR TB, and I want to support the patients as much I can. If I have the knowledge, I can pass this knowledge to my colleagues who will treat these patients. So I am working now in MDR-TB at the Challenge TB project, and I work at national, provincial, district, and the community level, as it was mentioned. I'm involved in the national committee at the national level who take the decisions, who implement the decisions based in evidence, but I also work at the community level, and everything that I see at the community, I talk with the patients, I see their difficulties, I make sure that these difficulties are covered and I bring to the national level. So I am also the voice of these patients that are there at the rural area with their difficulties, and when we discuss, I make sure that with our own conditions, we can cover the needs of these patients.
Great, thank you both. Those were really interesting and compelling stories. And obviously, you both faced a lot of challenges with the diseases you had. And yet, at the same time, you had a lot more resources than some of your average people in the poorest billion that Jean was referring to earlier. So based on your own experiences and experiences you've had with other patients, either as a provider or in the dialysis unit, what do you think can be done in order to improve access to high-quality care for patients and achieve UHC in some of these countries?
Thank you. For me, on my side, I really believe that we need to involve people living with these conditions in all levels of conversation. So whether it's the government or even at the community level, we are people too. And so I really like the program where people living with these conditions go out and talk to the community. And I feel like when we do that, we let the community understand how important it is for them to look at the healthcare systems they have and how they can push for that in the political way or through the government. Because when we talk about our stories, we give you a snapshot of how it is to, for example, have kidney failure or how it is to have MR-TB. So I really believe that we need to be involved. And then I also believe that we can be involved in preventative health, and that's I would say it in this way. I would say, like, for example, when the community health workers go out to the community, they can go with people who've had these conditions, and that would help the preventative health, because when you meet someone who's gone through a condition like mine, for example, like if I go and tell someone, hey, I was on dialysis and I understand what it is not to take care of your kidneys, for example, or to check your blood pressure, that is a key. It would move someone as compared to just interacting with the community health worker, for example. So I believe if we would have programs where the government would use us as people living with these NCDs, it would really help, because a lot of my friends who've gone through this end up staying at home. They don't do much. So I would love if our governments could integrate us into the healthcare system, or even with the healthcare workers, to just reach out. Thank you.
Great, thank you, Maria. And let's keep answers to like under 3 minutes or so.
Okay. I wish all these patients at the community have the same treatment, the same support as I had. I'd like to have this, the diagnostic means close to them. the best medicines that they can, shorter regimens, not the ones that I had to go through for 2 years, free of injections, shorter regimens. And also, I would wish that these, all the politics or policies that talks about out of the pocket expenditure be translated in facts, benefit the patients, because at the moment I don't feel that they are benefiting. With the disease, they complicate their lives. They become more poor with less health. So I wish that all these innovations that likely has been put in place reach those on needs.
Perfect, thank you. So I think that is something that's really important in this discussion is access to essential medications, to the newest regimens, to improved diagnostics. And something you and I were talking about yesterday, Maria, that you didn't mention is human resources. I think this is a critical issue that many of these countries are facing, severe shortages of trained healthcare workers across the whole spectrum. So with that, we're going to move to our second discussion group. So we are going to hear today from Mr. William Osius, who is a community health supervisor from Zanmi La Santé, or PIH Haiti. He has been with Zanmi La Santé now for 11 years as initially a community health worker, and then eventually was promoted to a CHW supervisor. He comes, interestingly, from a long line of community health workers. So his father was a CHW for over 32 years, really his entire adult life. And as he was a child and he was in school, people in the community actually came to him and said, "We think you should also be a CHW." So this was really a calling for him. And then next, we're going to hear from Miss Marie Ketty Tupoisson. She is a registered nurse and the community health nurse coordinator for Zanmi La Santé. She has been a registered nurse since 1994 and has been with PIH since 2004. She is responsible for community health across 2 departments in Haiti and works with over 300 community health workers, as well as a large cadre of nurses. She was trained in global health delivery at Harvard, and I was trying to keep these introductions short, but this was in the notes and I have to include this part. So she is a master writer of community health jingles, so maybe if she has some time later, she can give us an example. So I'm going to turn it over to them. First off, I want to ask, what are the barriers to delivering healthcare and achieving UHC as far as you see it? Sorry. That's okay. From your perspective in low-resource settings like Haiti.
Bonsoir à tout le monde.
Good afternoon, everyone.
Moi content parmi nous aujourd'hui pour moi parler de expérience moi sur terrain en Haïti.
I'm so excited to be here to talk about my experience on the ground in Haiti.
Jean madame n'a déjà dit moi c'est William Osius, moi c'est superviseur de terrain.
As Alicia said, my name is William Osius. I'm a supervisor for community health.
Alors seulement moi travaille dans des zones qui très difficiles.
I work in some of the hardest to reach areas in rural Haiti.
Moi besoin 4 heures de temps dans zone mal travail pour marcher monter mon.
Where I work, I have to walk 4 hours each way to see my patients.
Malgré ça, nous utilisons des stratégies pour que le service soit capable de joindre moun yo dans la communauté.
I use all the strategies I can to ensure that I'm reaching every patient, even in all the mountains.
Moi voulais partager avec nous quelques activités que nous réalisons dans la communauté.
I want to talk to you about some of the activities we do in the community.
Moi voulais parler de post-rassemblement.
I'm going to talk first about our assembly posts.
Post-rassemblement, c'est une stratégie que santé communautaire mette en place pour que le service soit capable de joindre moun yo côté où est.
This is a strategy we've put in place so that we can bring health to everyone, regardless of where they live.
En dedans post-rassemblement, ça, nous faisons éducation.
In these health post gatherings, we do education.
Après éducation, nous faisons mensuration, ça veut dire nous faisons contrôle malnutrition ti moun yo.
We do we provide different services such as screening for malnutrition for babies. And children.
Non fait administration sous vaccin qui sous épidémiologie et qui MSPP nous fait vaccin pour ti moun sa yo.
We do vaccinations for children.
Après ça nous fait distribution vitamine A.
We also do vitamin A distributions.
Nous fait déparasitage.
We also do anti-parasital administration of medicine.
Nous fait planning familial.
We do planning, family planning.
Yeah. Nous fait distribution et contraceptive capote.
We give out condoms and other contraceptives.
Yeah, ça veut dire justement nous fait activité ça pour moun yo capable joindre service parce que moun nan besoin 3 à 4 heures de temps pour li marcher sorti dans zone côté liya pour l'arriver dans institution pour prendre service ça. D'abord même si nous t'a sensibiliser li pas aller, c'est ça qui fait santé communautaire mettre stratégie ça juste pour moun yo capable joindre service ça.
And when we do this because can you imagine if you had to walk 3 or 4 hours to get to the hospital? We can tell people to go, but they're not going to necessarily be able to make it. So we bring the services to them.
Nous fait visite domiciliaire.
We do house visits.
Qui c'est un point très important.
It's very important.
Dans la visite domiciliaire, nous bail conseil.
We give advice.
On fait observation tout.
We observe.
Et il y a des patients qui sont très importants pour nous, surtout patients maladies chroniques.
And of course, the ones that we take most attention on are those with chronic diseases.
Parce que pas oublier agent santé yo connecté avec institution en tout.
Because don't forget, we're connected with the health facilities, the primary and secondary facilities.
Parce que il y a des gens qui connaissent aller à l'hôpital là, ils pas aller dans rendez-vous, ça c'est responsabilité agent santé yo pour visiter moun nan, ba li conseil, demander est-ce qu'il prend médicament parce que il y a des gens qui kon recevoir médicament dans même médecin, les rivé, li boit médicament fois, après ça il dit li fait tel bagage, m'ba choisir prendre, mais faut gen moun, faut gen agent santé qui pour supporter, qui pour faire li prend médicament ça.
The nurses and doctors will call us if a patient isn't making it to their appointment because we have to make sure that everyone's not missing a dose. It's so important. So we'll work hand in hand with the health facilities to ensure that patients are not missing doses. We might even pick up the medicines for them, make sure that they're getting them.
Nous fait des réunions communautaires, c'est parler avec leader yo de l'importance vaccin, yo même tout aider nous sensibiliser l'autre monde pour que moun yo len gen rendez-vous avec yo pour venir prendre service ça pour capable venir.
We make sure that health is not just the job of the community health workers, but all of the community leaders. We do meetings with them and we ask them to engage and make sure that when we're doing health service provision, that they're helping us to make sure everybody is making it to the points of service.
Même leader ça yo nous fait des rencontres trimestrielles avec eux pour nous parler de nutrition tout.
And we also work with these community leaders every quarter to make sure they're getting different education topics.
Nous faisons des séances sur santé maternelle.
And we work with maternal health.
Nous réalisons des clubs des jeunes.
We have youth clubs.
Clubs des mères.
Moms clubs.
Et nous même fait club pour patients maladies chroniques.
And we also have now a club for people with chronic diseases.
Nous faisons des clubs et des séances pour nous parler de l'importance de la vaccination.
We want to make sure everyone is vaccinated, so we have clubs for that as well.
Nous faisons des séances sur tuberculose, maladie tuberculose.
We train on tuberculosis.
Alors, moi, je veux partager une expérience ensemble avec nous.
I want to share one experience with you.
OK, moi, j'ai gagné un monsieur qui était tout près de la caille.
I had a patient who lived right near me.
Et puis, moi, sorti travail, moi, j'étais à la caille.
I left to go to work. I had come back from work. I was sitting at my house.
Li chita en face moi la caille.
He was sitting looking at me right across from me at his house.
Même il y a quelques jours que me bat jamwel.
I had maybe 3 or 4 days I hadn't seen him.
Et puis li chita do tourni. La caille li chita do tourni.
He was sitting naked right at his house right in front of me.
OK, et puis pendant m'a suivre lui l'a toussé moi tout zo ça paraît.
Okay. He was coughing and he could see the bones in his chest showing.
Yeah. Et puis moi déplacé, m'aller me saluer.
I went over to him and I said hello.
Moi m'a dit comment lié.
I asked him how are you doing?
Li dit quelques fois et non pas ouais mais il était malade très grave.
Li dit ou pas kon oh sorry. I started speaking Creole. He said sometimes you don't see me because I was so sick.
Li dit moi, li malade parce que li était dans discussion terre en moun envoyé en batterie en mystique bagay mystique sur lui.
He said you don't see me because he was really worried because somebody had sent him a spell on him. They put a spell on him.
Qu'on y a moment dire qui ça ou fait?
What did you do about that? he asked.
Li di mwen li gon kabrit, li vend kabrit la pour chercher kob pour la gérer dossier mystique.
So he said he sold a goat so that he could pay to go to the traditional healer to provide for this.
Mwen aksepte avel, ba gen problème avel pou sa mdi.
He said, of course, I'm not going to tell him what he did was wrong. I accepted that.
Et puis après me dit mwen ka ba ou yon conseil.
I said, but can I give you some advice?
Li di oui.
Of course.
Mwen di pou ki sa ou pa ale l'hôpital, ou pa jamal li di non, pa jamal l'hôpital.
Why didn't you try to go to the hospital or the health center? And he said, I didn't go.
Malgré te gen moun mystique la ki sou li, mwen di est-ce ka mande moun nan et pour aller l'hôpital, m'a pas accompagné ou bien m'a ba ou yon référence pour aller l'hôpital.
Even though he was seeking treatment at the traditional healer, William asked, would it be okay if you go together with the traditional healer to the hospital?
Li di mwen fok se mwen ki ta déplacé al pa la moun nan.
He said, but William has to go talk to the traditional healer for him.
Mwen déplacé vrai, mal parler avec ou gan, mwen di li, m'a mené moun sa à l'hôpital, li pa besoin gen problème, ba m'empêcher le fait travail pal, même conseiller moun nan pou aller l'hôpital.
And he convinced him that it was okay to go to the hospital, but they would continue the other treatment as well.
Et après, moun nan accepté pour aller l'hôpital la vrai.
His neighbor decided to go to the hospital.
Mwen tap ba li yon référence, li di mwen, kob mwen gen la seulement c'est pour me payer moun ki va faire bagay mystique la pou mwen.
He said, I gave him a referral note to go to the hospital, and I helped him pay for the traditional healer's fee.
Mwen accepté accompagner mwen menen l'hôpital la.
And he accepted to be able to bring him to the health facility.
Le mwen rive ou fait examen pour li.
When we got there, of course, they immediately did the tests.
Résultat révélé que moun nan fait tuberculose.
Of course, he found that he had tuberculosis.
Et après, mwen retourne joindre même ou gan ça.
He went back and told the traditional healer.
Mwen di ou pas besoin qu'un problème, ou ka toujours continuer faire ça faire, m'pa empêcher faire l'argent, mais moun nan m'a pédo pour traitement fait plus rapide.
I'm not going to take your patient away from you, but I am going to tell you that I'm going to help him get better quicker by having him have the medicine. I'm not going to prevent you from also doing the work you're doing.
Et le ça m'dé tout accompagner moun ça m'dé tout non accompagnateur pour lui, toujours bal conseil, fait la rendez-vous tout ça, et moun ça a arrivé joindre traitement.
And after that, he decided he took it upon himself to be the accompanier of his neighbor, and he helped him make sure he took all 6 months of treatment, and now he's cured.
Et moun sa tellement dit merci, li pa gen bouche pour dire merci, ou gan remercier m tout, et le ou gan fin remercier m, li tout ken be collaboration avec m, chaque fois le gon moun vinn la kay li, ki la fait l'autre bagay toujours mandem, et dem pou m voye moun sa à l'hôpital.
And he said, since then, the traditional healer and the patient don't have enough words to thank him for all that he did for them. And now the traditional healer and William work very closely together, and they refer patients to each other.
Tout ça c'est important, ça agent santé a.
This is the importance of the community perspective and the community worker.
C'est ça que fait di agent santé a c'est pour tout mi-temps.
That's why they say community health workers are the pillars or the bridge.
Parce que nous vivons dans communauté.
Because we live in the community.
L'el gon problème c'est nous avant.
When there's a problem, it's us that sees them first.
Nous gain pour devoir c'est référer l'institution qui.
And our work is to refer patients so that they get the treatment they need and then to follow them.
Nous gain pile rencontre de sensibilisation nous fait sur des maladies surtout malaria.
We do so many different meetings all the time on different topics.
Et nous même sur formation, yo apprendre nous comment pour tester moun pour malaria sur terrain.
And we continue to receive ongoing training so that we can then continue to be better providers of care.
Nous avons l'autre programme qui agent santé au participer qui c'est GNI.
And the last thing I'll talk about is a new program that we have called J9.
Parce que nous avons responsabilité et visiter femmes enceintes sur terrain et les jeunes se référer dans l'institution pour aller faire suivi.
It's part of the maternal mortality prevention work where we follow up moms who've just given birth at the hospitals to make sure their babies and themselves are healthy.
Et après, ils retournent dans la communauté avec nous.
And we have linkages. The nurses send us to check up on the patients.
Nous sensibiliser pour que yo accoucher à l'hôpital.
And we help encourage moms to deliver at the health facilities.
Et là, au final, accoucher à l'hôpital, là, on retourne, on a pour devoir pour toujours visiter, ouais, comment ti moun na fait checklist pour lui.
And he's always visiting the patients and checking up on them.
Merci.
Thank you.
I'm just going to briefly remind each of the speakers to try and limit your remarks to 3 to 5 minutes. Thank you.
Bonsoir.
Good afternoon.
Moi, c'est Marie-Kéti Tout-Puissant, Jean Yossodil là. C'est un plaisir pour moi et un honneur pour me parler là dans nom Zami la Santé.
It's a pleasure to be here and to be able to speak on behalf of Zami La Santé Partners in Health.
Depuis matin, moi dans salle là, moi dans assistance là.
I've been here since early this morning in this same room.
Moi tendais à parler de soins intégrés.
I've been hearing about talking about integrated healthcare.
Et genyen yon ti dicton la kay mwen ki di sel pa jam vante tèt li pou l'di li salé.
There's a Haitian proverb that says the salt does not ever tell itself that it's salty.
Mais nous-mêmes en Haïti, nous goûter sel Zami la Santé, c'est une occasion pour moi pour me dire Jean sel ça li bon pour nous, li salé pour nous, c'est nous-mêmes qui capable dire pour Zami la Santé, pour ça li fait pour nous parce que Zami la Santé pas qu'on fait marketing pour tête li, mais c'est nous-mêmes qui joindre service yo en Haïti qui capable dire ça pour lui.
But I'm here because I have to give a little salt. I have to talk about this salty because Zami La Santé Partners in Health, they do services, but they never talk about it. They don't go around bragging about what's happening. They just do the work. And I need to say that.
Ça que m'te vle di, l'aime t'entendre à parler de soins intégrés, moi ça pas nouveau pour moi en Haïti grâce à Zami La Santé.
When I look and hear about what the Minister of Rwanda and others were talking about integrated care, I'd say this isn't new for us. We've been doing this thanks to Zami La Santé.
Parce que Zami La Santé, il était commencé en 1985 avec programme VIH/SIDA, mais il était venu que importance soins intégrés et au fur et à mesure il entrer dans plusieurs programmes et c'est ça qui fait qu'on nous capable dire que nous avons soins intégrés parce que nous gagnons toute qualité spécialité nous gagnons toute qualité spécialiste qui bail soins intégrés au niveau de Zami La Santé dans et santé reproduction dans maladies infectieuses dans maladies chroniques dans soins maternaux infantiles.
And we started providing HIV care in 1995, but in the years since then, we've been doing an integrated care platform. And so today, I can say that we have all the different kinds of specialists who are able to provide care for not only chronic diseases, infectious diseases, maternal and child health care, and all the others.
Moi responsable en pile site dans Zami La Santé au niveau de Plateau Central et Artibonite.
I'm responsible for working with different health facilities and catchment areas in the Central Plateau and the Artibonite of Haiti.
Dans tout site ça que Zami La Santé yé,
in all of these facilities where Zami La Santé is,
yo joine chance pour capable joindre ça n'a parler de langue de soins intégrés.
Anyone who's at these public facilities, they have the chance to receive integrated care.
Ça que moi remarqué en pile fois, Zami La Santé t'a vle pote chay l'état dans pays sous dol parce que c'est 10 départements dans pays qui al chercher service dans tout site Zami La Santé.
I have to say that sometimes it's appearing as if the government is trying to put the weight of all of the services for all 10 departments of the country on the backs of Zami La Santé because people from all over the country come to these facilities.
Moi dis non merci en pile parce que nous t'attendons mon prêt pour question qu'on y a.
Thank you very much for listening to me and I'll be excited to hear your questions.
Thank you very much, Ms. Ketty and William, for those very impassioned remarks from both of you, highlighting things like access to care, transport issues, kind of overburdening of healthcare workers, as well as the importance of having a deep knowledge of what's going on in the community and what the patient perspective is. So I'm sure there will be more questions for you from the audience shortly. At this point, I'm going to move to our third group of panelists. So I'd like to introduce Dr. Jones Massier. He's the Deputy Director of Clinical Services, responsible for NCDs and mental health at the Ministry of Health in Malawi. He's also the co-chair of the Malawi NCDI Lancet Commission, as well as being the project manager for the World Diabetes Foundation's Diabetes and Hypertension Control Project in Malawi. So he has got his hands full. And lastly, but definitely not least, I'm going to introduce Dr. Terry Reynolds. She is a scientist in emergency trauma and acute care. She is part of the WHO's Department for Management of Non-Communicable Diseases, Disability, Violence, and Injury Prevention. After many years of working with the WHO, Dr. Reynolds joined them in 2015 to lead their emergency and trauma care program. She previously ran the emergency residency program at the National Public Hospital in Tanzania and has also worked with many countries in the Afro region on emergency care strengthening as chair of the scientific committee of the African Federation for Emergency Medicine. So we're so excited to have you both here today to provide the ministry perspective from Malawi and also more of a global perspective from WHO here in Geneva. And want to hear from both of you, starting first with you, Dr. Jonas. What do you see as the major gaps in UHC policy in terms of strengthening health systems and ensuring the full burden of disease in low and middle income countries is met? And how does this translate into goals for you this week while you're here at the World Health Assembly and in the future at UNGA and the UHC high-level meeting in the fall?
Thank you very much for having me here. It's a pleasure to be here. And also let me take this opportunity to say I have my Chief of Health Services from the same ministry, Dr. Charles Monsambo, who has accompanied me to this. So I'm grateful. Looking at your question, I think let me start by saying, like Malawi Ministry of Health and Population, we have a health sector strategic plan, which started in 2017 to 2022. So basically, it focuses on the delivery of free essential health package access at a point of care, irrespective of whether somebody is able to pay or not. We have tried this, and though it's working, but yes, there are gaps. Gap number one, I think it's human resources for health. This is a thing that is, giving us headache. The ministry has tried together with the other partners to make sure that we have enough human resource, but still we cannot, deliver the services properly. Let me give an example. For example, anesthetists in the country, we have 1 per 100,000. So I believe they cannot work efficiently. So we need to do something on human resources for health. The second gap that we have noted is the financing gap. For example, on non-communicable diseases and injuries in our country, they contribute to 30% of burden of disease. But we do not have a budget line for them. So normally it's either through partners or even other finances that we can use to deliver the services. And the third, when it comes to disability adjusted life years, so which means something that is a 30%, it needs to have resources for us to make sure that we manage these conditions. The third gap, so I have three major gaps. The third gap should be drugs and supplies. With the awareness campaigns we have in terms of, I'll talk in terms of non-communicable diseases and injuries. A lot of people have come to the facilities now to make sure that they get screened, and those whom we have found with condition, they should get treatment. This has put a pressure in terms of drugs and supplies. Sometimes patients have to walk long distances to make sure that they get drugs, but you find that in some of the facilities, the drugs are not available. So I believe these are major gaps that I've seen in the delivery of universal health coverage. So I believe if we can address this, we are likely, yes, to manage this condition.
Great, thank you. And Terry?
So I think one of the most powerful things about listening to these stories is that no matter how we think about this, there are so many different ways to approach this. There's the very abstract, acronym-filled UHC, PHC, JWT, that just is pervading this, couple of hundred square meters here this week. And then there are ways of looking at it as diseases, and then there are ways of looking at it as patient stories. And they come together to give a much more complete picture, and I think to inform much more effective action. One of the things that struck me listening to the stories today, well, the first was, of course, that really, really, really prevention is infinitely better than cure. So that, one of the things that came forward so strongly through this is treatment is extremely hard. Treatment is just extremely hard. And so that's one piece of it, and I think it's important that we don't forget that. Now, that said, there's an interesting there's an interval that happens between when a person has the onset of an illness or an injury, when a person has symptoms, and the moment when they belong to a diagnosis, a department in the hospital, a WHO program. And it's interesting because even the stories told today, to some extent, were told through the lens of rheumatic heart disease, chronic kidney disease, MDR, TB, HIV. And unless you are the incredibly insightful provider who narrows your own diagnosis, I suspect that each of you, the conditions that were described today, that there was a moment where the primary problem was difficulty breathing. And there is an interval between the moment when a person experiences difficulty breathing and the moment where we know how to align the services and the resources and the responses that we have. And that, I feel like, is often left out of this and the planning around that. And to some extent, I see this bundle of kind of emergency and acute care as responding to that. And time was not mentioned. And so some of these are slow-moving conditions, the ones that were described today. But when you talk about access, we talk about access to effective services. Probably 3/4 of the effective interventions that WHO recommends, the effectiveness goes down with time. So for the most part, your interventions will eventually become ineffective if time goes by. So that is a gap I see often, this idea of narrowing from a chief complaint to a diagnosis or even a provisional one to which you can align your services. That is almost never strategized in these UHC agendas. And then time almost never appears in these documents, which is quite extraordinary. So I guess I think, there's a lot of ways to look at that. I think of kind of integrated emergency and acute care is being not something that needs its own attention or its own indicators or whatever, but something that sort of amplifies the impact of every other investment in the health system. And I think it's interesting that even with these stories, they start with the diagnosis, because I know there was more behind that. And that just, all that says to me, I guess, is that it's very, very powerful, this way of thinking about responding to health problems. It's so powerful that even with people telling their own stories, we jump over that interval. And we certainly do it in our UHC programming. So I guess that would be my call. Just every time you write a document, ask yourself if the word time should have been in there somewhere, or timely, or and then ask yourself, is there a strategy? What did that person have? They didn't know they had a surgical condition. They didn't know if the difficulty breathing was a heart attack or an infection. So has that been strategized? There's not one way to do it, but have you, in whatever plan you're making, whatever story you're telling, whatever solution you're proposing, has that interval been strategized in some way or addressed?
Great, thank you both so much. Dr. Jones, it was really helpful to hear about the free and essential health provision in Malawi. I think it's a very progressive stance that Malawi has taken, but as you've identified, there are still many gaps that really need to be addressed, and that's kind of what we're here to talk about, so I'm glad that you hit home on some of those so clearly. And Dr. Terry, I think it's a very important point that you brought up about access not just to high quality care and effective care, but without that acute and timely piece that we're missing so many, that we're not getting patients what they need in an effective way. So at this point, I want to open it up to the audience who's been very patient with us for some general question and answers. We do have microphones that people will be walking around with. So any questions for our panelists? Yeah. Where's the microphone?
Okay, thank you very much, the panel. My question goes to William of Haiti. As a community health supervisor, I know how many community health workers are you covering to supervise? And you have already stated here that you work 4 hours going to the site of where the community health workers are. That's a big challenge to cover maybe a wide area to do proper supervision. What is the plan, future plan, to ensure that you have access to the people and not to travel those distances? We have a similar program in Malawi of community health workers, and now we are struggling to ensure that the distance to where they are staying is closer to where the communities are. So for Haiti, what is your plan? The third issue is like the training. How much have you been trained? How many years have you been trained to be a supervisor, or how many, what is the period of training for the community health workers that are working, for you? Thank you.
Section communale côté mwete a gen 54 localités.
There are 52 small villages in the area that he works in.
Nous gagnons 18 agents de santé qui divisent en deux parties. Nous gagnons des superviseurs, moi-même avec une autre demoiselle.
And there are 18 community health workers for those 26 villages, and there are 2 supervisors for those 18 community health workers.
Ça veut dire moi gagne 9 sous supervision, moi gagne 9 sous supervision l'autre demoiselle là.
And he has 9 and the other has 9. Okay. And Ms. Ketty will respond to the other piece.
Selon protocole ministère santé publique mété, li mandé pour chaque agent de santé gagne sous compte li 1000 ménages.
According to the national strategy for Haiti, there's 1,000 households per community health worker.
Donc nous-mêmes lui-même li sorti dans commune mi en balai que zami la santé lui-même lié dans zami la santé yo mandé pour nous gain et nous suivre protocole ministère là grâce à un programme renforcement que nous t'ai bénéficié côté chaque agent de santé yo gagné sous compte yo vraiment 1000 habitants et nous gagnons superviseur qui capable superviser un quota normalement de 9 à 10 agents de santé.
So according, again, to the national strategy, there's the 1,000 households with the community health worker. The quota is that they shouldn't, the supervisors shouldn't be having more than 9 to 10 community health workers that they're supervising. Mm-hmm. Very different from the Malawi model. Okay.
We have 1 per 1,000, so it's similar, the same, and the supervision is the same. Like we have 1 supervisor per 10, community health workers. Yeah, so it's almost the same.
Other questions?
So I wanted to know, you were lucky to have strong support from your loved ones and friends. I wanted to know if there was any type of program ensuring mental support for patients with chronic diseases in your respective countries, for the people who don't have a support system. And if not, how important do you think that should be worked on?
Excellent question. We were actually talking about that just before the event, so.
Thank you for the question. Yes, we were talking. I think that psychological support is very important for the patients. Not just for the patients, for the whole family. The whole family need to be involved. They need to be informed about the disease and what kind of support they can give to their loved ones. And in Mozambique, we are now reinforcing this psychological side. At the national level, at our national committee, we do have a psychologist that is responsible for training. During our trainings, we also train the psychologists, and we use the HIV psychologists also to support the patients. This is very important. The education for adherence, the counseling that the patient needs, and even for us as providers, how do we address this part of the patients? So we communicate with them. I make sure that at least for those XDR patients that are very few, I communicate with them almost every day through WhatsApp to find out how are they, to give them courage to continue, to encourage them to be persistent on their treatment and adherent. This is a very important component.
For me, on my side, I'll say that our country does have, but it's more in the referral hospitals, especially in regards to chronic kidney disease. So once they find out that someone has chronic kidney disease, there'll be someone to talk to them about it, and it's usually a doctor. And we don't have many social workers, so the social workers tend to be overwhelmed. So a doctor is the one who will kind of explain and talk to them about it. There's still a lot of stigma in regards to kidney disease, so the people, when they find out they have it, they usually don't tell their family, or they try to avoid telling many people. So that's a big barrier in regards to just talking about it and having that conversation. As Maria Jose said, it's something that we need to do more of, because it'll help us improve the whole system. But if we don't talk about it, then yeah, it's something that I think most African countries would have to integrate that more, because it's still at the point where we're stigmatized for it. So when someone finds out you have kidney disease, they're more likely to say you're being cast. So there's some sort of that kind of conversation or narrative as regards to support.
I see a lot of hands up. We're going to take one more quick question with a quick answer.
Oh boy, that's a lot of pressure. All right, Chris Maddox, Managing Director, Seed Global Health. It's a question for the Malawi context to kind of bring it back to the equity piece. So you talked about the huge challenges of so few health workers and trained health professionals, but then you also have a rural and urban inequities as well. Can you talk about how important it is to solve, for you all to solve both the gross number of trained health workers and then strategies for addressing your disparities in country?
Right. Thank you very much for that question. So, yeah, you are right. Basically, looking at this issue, we're saying if we can train more human resource, we are likely to provide these services to everyone. Let me take you back to what my colleagues, Dr. Maria and Wako, and even the boy from Nepal. Basically, we need to bring these services close to the people. How do we do that? We need to train more health personnel to make sure that, we address these disparities. So I believe if we can start with that as a main thing, we are likely to reduce most of these problems in the country.
Wonderful, thank you. So I have one final question for each of our panelists. Want just one quick 30-second answer. What you see in the context of the upcoming high-level meeting on UHC as the one key recommendation you would make to the United Nations, the WHO, member states, and civil society. What one key issue should people mobilize around in lead up to the high-level meeting? We can start with you. So, in brief, just if you were to give one key recommendation to member states, the UN, the WHO, what would it be?
Thank you. I would give the statement that we should be involved in decision-making platforms like this because we have experience of the disease. This is something that I've lived through, and I believe that when we talk about it and we're able to connect on a personal level, you can see through our experience what it's like to walk with this condition. Thank you.
I've got many, but I'll try to do it fast. First, the patient side was already addressed, but I will also mention on the health worker side. We want to have better conditions. We are at risk, we are exposed, and the health workers also has to be seen as a human with their needs. She also mentioned on psychological side. We deal with patients, we deal with lives, we get frustrated, we want better conditions, we want this psychological support. We want to have rapid diagnostic tests, better medications, short regimens, means for diagnosis, means for monitor patients, and also to have this out of the pocket really working for the patients. Thank you.
Right. I think for me, one thing I will still, which is on top of the list in terms of recommendation, it's human resources for health. Because, for example, in Africa, we have some structures or facilities which are not operational because people are not there. If we train more, I think we'll have a push factor. People will be able to go to these facilities and work. So human resources is on top of my recommendation.
Thanks. It's always fun to get to give yourself advice, I guess, if we're advising what WHO should do. I try to do it most days. Look, I think there's just a framing, as we talked about, of kind of once upon a time, and then there's a linear narrative to the story. And I think that's very rarely the way that people experience illness. And a lot of our health system programming is magical thinking. We would like it to be such that there is a perfect world of primary care, and then this happens, and then this happens, and then this happens. And the truth is, I think it would be very powerful if we could stop for a minute and recognize that what is happening in most chronic diseases is an oscillation between one side, which is kind of preventive and longitudinal care, and another side that is acute care. And people with chronic diseases, some of the most difficult moments in their lives are the acute exacerbations of those chronic diseases. And at times, with diseases like asthma or heart failure, the very fact of having had an acute exacerbation changes your chronic diagnosis and your longitudinal therapy, depending on its frequency, for example. So just this idea that really more accurate descriptions from people who experience illness, we haven't done a very good job of mapping this oscillatory movement between acute and longitudinal care, and that is making our programming less effective. Our wish that were not the case is making our programming less effective. And so I think the mechanism for remedying that is more direct input of people who are experiencing illness over time, I think.
Recommandation PAM nan li basé sur décentralisation.
My recommendation is based around decentralizing care.
c'est rendre centre de santé yo fonctionnel parce que la caille moi gon gros rivière depuis la descend ou te mettre à une femme enceinte li kon fait nuit la descend ou pas ka traverser.
Right where I live, there's this big river, and when it's raining at night, oftentimes the river gets so high that if a woman was pregnant, she wouldn't be able to make it to the nearest health facility.
Et puis li basé sur trois ressources, ou besoin monde, ou besoin matériel et ou besoin ressources financières.
I have three recommendations. You need people, they need to have the supplies they need, and we need the proper finances to make it happen.
Merci.
Et recommandation PAM, m'a dit là avec un cœur qui est un petit gens serré.
Mine is, I'm telling you, with a kind of closed heart.
Parce que m'a regardé dans pays, m'gen pile bel plan qui écrit sur papier. Donc m'ta souhaité que dirigeants dans pays yo prend engagement yo pour yo appliquer ça yo écrit sur papier parce que gen bel plan qui écrit mais malheureusement pas de sécurité sociale. Imaginez même un fonctionnaire de l'État quitte lycée policier, quitte lycée médecin, quitte lycée infirmière, quitte lycée professeur, li gen une assurance santé qui écrit dans papier que le gagne, yo pas recevoir le pièce côté parce que qui ça yo dit comme ça l'État pas prend engagement pour capable rembourser frais ou pas gain assurance.
I will do my best. So, my recommendation is that we have beautiful plans. We have lots of beautiful plans that are written on paper that the government has made, but I want to see them in action. We all health workers that work for the public health system, as well as any government employee, whether they're a teacher, whether they're a police officer, supposedly they have health insurance, but in reality, it's not able to be attained anywhere. So I hope that the people from my country, our government, are listening and able to help this happen.
Thank you, Ms. Ketty. That was a perfect way to close this panel, and I want to thank all of our panelists. This was a great discussion. I think we've heard a variety of perspectives from our panel today, but there's a few key themes that emerged. I think the final words of Ms. Ketty are one of them, really, which is we can have all the beautiful plans on paper, but if we're not taking a hard look at what it takes to actually implement high quality care, and that's the human resources that have been mentioned over and over again, that's infrastructure, new diagnostics, the drugs, the systems really that make all of these things function. Without those and without people trained in every different aspect of care, whether that's NCDs, whether that's infectious disease, whether that's emergency care, surgery, mental health, we've heard about the importance of all of these things today. And I think we often take a kind of siloed approach to one particular area. And that's not what we need at the end of the day as patients, as people. We need access to real quality health care for everyone at every level and in every service area. And as Terry pointed out, we need it in a timely and efficient manner. So, I've heard a lot this week about improved efficiency, about domestic resource mobilization, and I think those are important points, and we need to work on those. But what we really need to do as a global community is come together and take a hard look at what it takes to make these systems function and together come up with the resources to really have effective, high-quality care. So thank you so much.
Walking off the stage, I have the pleasure of introducing our final speaker. Thank you, everybody, for staying. It's been a 2-hour session, but it's amazing that so many people have stayed to the end. So Dr. John Mira, he's the Kletchen Professor of Global Surgery at Harvard Medical School. He's the Plastic Surgeon in Chief at Boston Children's Hospital. He's also my boss. So
Thank you. So Alicia Key told me that I have to keep it under 45 minutes, is that right? No, just a few minutes. I certainly can't recapitulate all the comments that were made here today. So I'm a cleft and craniofacial surgeon in Boston, but I'm not coming here to advocate for cleft and craniofacial surgery. And I'm part of the program in global surgery and social change in Boston. And I'm not here to advocate for surgery, OB, and anesthesia. And there are a number of people who know me in the room, and they're probably thinking, who is this strange person that's standing in front, and where did John go? And the reason is, as I was listening to the stories here today, I thought of something that Paul Farmer says, and he talks about the social construction of healthcare. And what he means by that is that a divine entity did not come down and give us healthcare, that we constructed it the way it is right now. And it leads to a kind of cognitive dissonance. And what I mean by that is that we all know that human disease is very complex, and we often have many diseases at the same time. And yet, in large part, we look at our systems, and they are constructed as if that weren't true, as if human disease was monolithic, and they were constructed as if kidney patients or kidney failure might not require a transplant or surgery. They were constructed as if cancer and pregnancy would never collide. And we know that those things aren't true. I just heard a great lecture about a month ago from a professor at American University of Beirut who talked about the management of the pregnant cancer patient. So we know that there is this inherent complexity. And yet our system doesn't seem to address that. But the powerful part of this meeting today is we heard, from patients, from community advocates, from national and international folks, that this is important. And we heard a diversity of the human condition and human disease. Honorable Minister Dimubanzi talked about a number of things: task sharing, prevention, community health, surgical planning, quality. He talked about the role of all sectors in health. And so this meeting was somewhat unusual in that you have surgery folks here, NCD, infectious disease. It isn't that often that you get this type of multi-stakeholder meeting like this. And so I guess my plea to you is that we really accept and embark on the opposite of what Paul Farmer talks about. So he talked about the social construction of healthcare. And I'd like to say we should embark on the social reconstruction of healthcare. And so that's why when I first came up here, I said I'm not coming as a surgeon, because we have to let go of that nomenclature and that restriction. So with that, I'll thank you all for coming. This was a great meeting and a great start to what I've just talked about. So thank you very much.